evening, friends. So welcome to our 101st webinar, an auspicious beginning. I welcome my colleague and close friend, Dr. Rajeev Soman.
Hi, everyone.
Was still about few years ago, was a consultant at Hinduja Hospital, but now has shifted to Pune and is at Jupiter Hospital. Dr. Soman is synonymous with infection control. So when we thought of doing the centenary celebrations on infections and antibiotics, there was no other person but Dr. Rajeev Soman who can talk to us. Like Suhas Prabhu was there for children. And fortunately for me, when I called Dr. Rajeev Soman, he immediately agreed. Today is an auspicious day for us that we are having our 101st webinar. And it is an auspicious day for Dr. Rajeev Soman. It's his mother's 90th birthday. Dr. Soman, we all wish her a wonderful birthday and a healthy and long life ahead. Please convey to her.
Sure, Chandu.
And as the rule at Inches Academy, we don't waste much time in introduction. All of you must be aware of Dr. Rajeev Soman. So I will hand over to Dr. Rajeev Soman without much ado. Rajeev Soman, Dr. Rajeev, have you received the cake?
Yes, I have.
So we'll cut the cake towards the end of the seminar.
Towards the end, true.
Yeah.
That was
okay. Please go ahead.
Yeah.
The floor is yours.
Friends,
you can share the screen.
It's indeed a great pleasure to participate in this excellent series of lectures. And of course, when as I fondly call him Chandu, that is Dr. Asrani. I mean, when he's got every right over me and over Suhas Prabhu and all that, he just has to, his wish is our command. Okay, and it's a pleasure to be interacting and also be talking on this forum. So with this, I start my screen share. Suppose you can see it. Is my screen visible?
Yeah, it is visible.
Yes.
Visible. Yeah.
Okay. So I'm going to confine my remarks, friends, to community-acquired infections. And what do we do with, how do we rationally treat the community-acquired infections with antibiotics with a view to manage resistance or minimize resistance? So are we really witnessing a dawn of a new era where we are going to use antibiotics rationally? Or are we seeing the sunset or the exit of the dawn or the exit of the era of the use of antibiotics? That's the question in front of all of us. And I think it's we who are going to determine what is going to be the answer to this. So my poser is, what is an antimicrobial? And I'm sure you all know from pharmacology and from medicine what's an antimicrobial. But I'll put it to you that it's a drug to which organisms develop resistance. Now, unfortunately, that has come to become the defining characteristic of this group of very valuable drugs. Now, just ask yourself, do antimicrobials develop resistance to insulin or to anti-diabetic agents, antihypertensive? No, obviously, because those are all designed to treat the host and not the microbes themselves. However, when we use the antibiotics, it's going to make a lot of difference because organisms will almost universally develop resistance given enough time. So it's very important to know what is this concept of rational use and stewardship. So stewardship basically means, friends, you are guarding something which is very precious and something which is very fragile. So are antibiotics precious? Obviously they are, because they save human lives. And are they fragile? Yes, they are, because the use of antibiotics leads to the microbes developing resistance. And this kind of a story of discovery, exuberant use, and rapid obsolescence is repeated for every new antimicrobial. No antimicrobial has escaped from this particular cycle. Interestingly, antimicrobials eliminate their own need in a given patient, and to that extent, they become victims of their own success. So the more successful an antibiotic, more is going to be its use, and more rapidly is it going to become useless. And it's very difficult in friends to find out new antibiotics, because basically you're trying to exploit new or novel microbial metabolic pathways which have to be found and which can be selectively inhibited, because we do not want the host to have lots and lots of adverse reactions. And therefore, because it is progressively difficult to find these new antibiotics, new metabolic pathways, and drugs which are safe, pharmaceutical companies are reluctant to make a big investment, because that big investment can become zero within a short period of time. And you and me have used these antibiotics in a rational manner. Rational mainly means something which can be scientifically justified. So when we treat any infection, we have to be clear in our mind, is this a therapy of a definite infection, or is this empiric therapy? So here we think that there is an infection, we don't know which is the organism, what are its properties, but we are going to treat because the patient is comparatively serious. So that is something what we call as empiric therapy or experimental therapy, so to say. Or is it a preventive therapy? Now, why do we need to be very clear about this? Because the type of drugs we use, the doses, the duration, everything will depend upon what is out of these three is in our mind. In any case, whatever is in our mind, we have to choose treatment which is going to have highest efficacy, least toxicity, reasonable cost, and least disruption of our microbial ecology. So this particular thing is also very important, and that is mainly with the view that you want to preserve the utility of antibiotics. So everyone of us knows what are the factors determining antimicrobial use. Obviously, it is for good intention. We want the patient to become all right. We want to cure the patient whenever possible, and so on. So intentions are clear. Intentions are very good. But do we have the adequate information and knowledge about what is wrong with the patient? Unfortunately, not. And in community practice or in family medicine and so on, it becomes even more difficult to have the adequate information and knowledge. So there are also lots of limitations of the diagnostic test. Apart from the expense, the turnaround time, that means when are you going to get the result? Is it going to come within a short frame of time or long frame of time? Plus the sensitivity, the specificity, the positive predictive value of a test, the negative predictive value of a test, all these things are extremely important when we judge what tests to do and what conclusions to draw after the result comes either positive or negative. Remember that sometimes even a negative test can be very, very useful. On the other hand, there is a pressure to treat, make the patient all right as soon as possible. There can also be some malpractice considerations. So, if you don't treat properly, there is going to be some litigation against you. And all this has really led to what we call as a spiraling empiricism. Okay, so more and more use, more and more resistance, so even further use, and so on. Sometimes pharma companies offer us very easy solutions. So it's not uncommon to see a medical rep coming out of this bag offering us magic remedies. This particular drug can kill all gram positives. This particular drug can kill all gram negatives. This particular drug can kill all of them, including viruses. All sorts of, they will promise the moon to you, but it's the education of our own self is our own responsibility. We really can't afford to be educated by the man who comes with the bag with all these magical remedies. And finally, it's very difficult to explain why to withhold antibiotics than to initiate. Now, let me take this example and let's see what conclusions we can draw from this case. So this is a 23-year-old patient who had abdominal pain, who was actually having a severe bowel gangrene, as you can see. So he had a gangrenous upper bowel and paraduodenal fossa hernia, and a lot of resection of the bowel along with anastomosis was done. So initially he was thought to have a pancreatic cyst for whatever reasons and was given piperacillin tazobactam in another hospital. So when he came here, his antibiotic was changed to meropenem. So what was found from that bowel, peribowel fluid was this E. coli, which was sensitive to meropenem. However, 10 days later, the patient had some other collection in his abdomen, and that showed that this was Klebsiella, and that was resistant to this meropenem. Now remember, the patient has been on meropenem, and before that the patient has been on piperacillin tazobactam. So where has this E. coli, where is this Klebsiella, which is so highly resistant? So it is even resistant to meropenem. So we call this as a carbapenem resistant Enterobacteriaceae. So where is it coming from? It's obviously not coming from the hospital. So it is coming from his own GI tract. So the GI carriage of these kind of Klebsiella pneumonia infections. So this GI itself is a major reservoir of this infection. So genome data indicates matching carriage and infection isolate rates in 80% of isolate. So basically what it means is this patient had this particular bug in his abdomen, which was selected by use of meropenem. And therefore, it is very, now how did he get this meropenem resistant bug? It was because probably he has received a lot of antibiotics before. So even patients who have not received much of antibiotics might still be harboring a small number of these resistant strains. But the moment you use meropenem, or before that piperacillin tazobactam, progressively what happens is you are eliminating the susceptible strains, and the resistant strains get a biological advantage. And therefore, I'll put it to you that stewardship begins at home. Okay, so resistance is often generated in outpatients or even in the environment, because see, after all, when antibiotics are given, they are excreted in the urine or in the feces, and then they are going to pollute the environment, so to say. So even environmental organisms are exposed to antibiotics, although that is not what we really want. If you use antibiotics in agriculture or horticulture, then obviously there is even more exposure. So the conclusion from this case is that these stewardship principles, that means rational antibiotic use, has to penetrate from tertiary centers to secondary to primary centers and even beyond. And I'll even put it to you that they may be as applicable, if not more applicable, to community medicine. Okay, so there is just no use trying to teach the ICU patient doctors that you should be doing good rational antibiotic therapy, because the patient is getting this right from his community. So that is why I'll concentrate a little bit on the use of empiric antimicrobials in the community acquired infections. So what are the common ones? Upper and lower respiratory, lymphadenopathy, diarrhea, skin soft tissue infections, urinary tract infections, and some undifferentiated fever. So let's discuss a few of these common conditions. So you have the upper respiratory tract infections. That's really the most common condition, which is associated with excessive and inappropriate use of antibiotics. Remember that most upper respiratory tract infections are due to viruses, and just almost less than 10% are caused by bacteria. So how does the doctor differentiate a viral respiratory infection from a bacterial infection? It's somewhat easier said than done in practice. But if there is a lot of rhinorrhea, laryngitis, hoarseness of voice, it really points to viral infection. There are very, very few bacteria which would be producing rhinorrhea as well as laryngitis. And secondary bacterial infection is something which has been told to us right from the time we are medical students, but really it occurs in a small number only. And perhaps in those patients, antibiotics can have some effectiveness. Now let's take this patient. He is a 35-year-old non-smoker with cough and malaise. Cough was initially dry, but now he has this thick yellow sputum. He has mild fever, lungs are clear, O2 saturation is okay, and the chest X-ray is clear. Now this thing about the green or yellow expectoration or discharge, again, something taught to us in our undergraduate days. It's not specific for bacterial infection. It is caused by this particular enzyme, which is found in white blood cells. It can be present in any, be it viral, bacterial, as leukocytes tend to aggregate to a mucous membrane. So it does not really predict a bacterial infection, nor does it predict a response to antibiotics. So merely looking at the sputum being thick, yellow, green, whatever, is not a reason for considering that this is a bacterial infection. Let's take this lady. She is pregnant. She has fever, cough, dyspnea. She is desaturated. And as you can see, there are these fluffy shadows. Now, this is an example from hospital medicine, but the messages from this patient are definitely applicable in the community. So antibiotics, ceftriaxone and teicoplanin given elsewhere, and the patient presented with this particular report, which shows Candida as well as Pseudomonas in this particular report. And the question is, what is the organism? So we know that Candida almost never produces pneumonia. It is exceedingly common isolate from the respiratory sputum, especially in patients who are treated with antibiotics. Pseudomonas is possible, but this patient is really not at a risk for getting Pseudomonas pneumonia. So this could be something else. So that something else turned out to be, where is that report? Yes, it shows para-influenza 3 was detected. So this is a type of influenza virus, and this diagnosis could only be made because of the use of this biofire, which is a respiratory tract multiplex PCR assay. Now remember, this is only done, it's fairly expensive, it is only done in hospitals. You can't go on doing it in the community medicine or family medicine. But when you found this, you found that all the other organisms which were isolated were colonizers. This whole syndrome was fitting into a viral pneumonia. And we know that there is no specific treatment for this para-influenza 3. So any use of antivirals is also of uncertain clinical benefit. Remember that she was also pregnant, so you would not like to use a drug which is an antiviral which has uncertain benefit. Okay, so accurate and rapid diagnosis of a viral respiratory infection is essential. We have often grown up with the idea that you rule out all other bacterial fungal infections and then say that this is a viral infection. Fortunately, times have changed now and we have these multiplex assays and so on. So this is something like a leapfrogging technology for the Indian physician. We never had tests for viral infection, but now we do have them. I agree that this test is expensive, not freely available, but in a selected case, it can be so very useful. You know, you could avoid so many antibiotics, antifungals, and whatnot in that pregnant patient. So timely, effective antiviral treatment can be given to those who have viral infections. Unnecessary antiviral, as in this patient. Now, supposing this had turned out to be COVID, then obviously we know that there are some drugs which we can use. On the other hand, or even for that matter, if it was H1N1 or swine flu, we could have used oseltamivir. On the other hand, unnecessary antiviral, antibacterial treatment can be avoided, or if it has already been started, it can be stopped. And that aids the stewardship by reducing the collateral damage to our microbial ecology. So what I said before, that the test is expensive, but actually it may reduce the total cost of treatment, because if you add all the total cost of treatment, prolonged stay in the ICU, it will probably be more than the cost of the test. And also you can adopt some preventive measures in those infections which are likely to be spread from one person to another, to the family members, to the other ICU patients, and so on. Another infection we see commonly in community practice is dengue. And this is just the usual dengue timetable, but this timetable is very useful because if we take a history properly, we can often make this diagnosis on the basis of this timetable, that there can be these symptoms, a little bit of remission, and then further fever with prominent maculopapular rash. And then that goes either to defervescence or the patient goes into a hypotension and dengue shock syndrome or something like that. So merely taking a good history and analyzing what symptoms occurred on which day of the fever and all that can help you a lot. Another infection commonly seen is chikungunya. And again, we know here that it has a very abrupt onset of polyarticular arthralgia and arthritis. In fact, the patients can actually recall the exact time and the joint which was first affected. The pain is very intense, and fever with a rash, especially something which involves a desquamation of the palms and soles, is something which is characteristic. So these features help you to say that this could be chikungunya. Obviously, it's a viral infection, and we do not need any particular either antivirals or any antibacterial treatment in this situation. Sometimes there was a time, friends, that diagnosis of many things was made by the physician's hands, eyes, ears, and even sometimes nose. And today, have we lost that ability. Physicians of today, you and me, are often lampooned by our patients or by the society, saying that we just want to rely, we have lost all clinical acumen, we have to rely only on sophisticated tests to make the diagnosis. So today diagnosis is made with the help of scanners, culture plates, histology, and certain genetic tests, virtual phenotype, and various other things. So really, have we lost something on the way? It's something which, a question which we need to ponder. I'm certainly not against any of these tests, but we have to be very, very thoughtful about how we are going to order this. Do we really understand something about the test? Do we understand what it means when it is positive or what it means when it is negative in a given patient? So another common problem in the community medicine is lymphadenopathy. And again, I would say that viral is a very common cause. So cervical, short duration, along with sore throat usually. TB is another important cause. And you could have supraclavicular, cervical, and others. A tender, painful lymphadenopathy with fever. Now remember that TB lymph nodes, generally the patient is not so sick and the thing is not so painful, and the patient usually doesn't even have fever. On the other hand, if you have tender, very tender and painful lymphadenopathy along with a fever, but shorter duration, think of Kikuchi-Fujimoto disease, especially in a young person, especially a young lady, which is much more important. And there are very, very few causes of bacterial lymphadenitis. Cat scratch disease, and some of them are, but really it is not so common. And yet you find that everybody with lymph nodes and fever gets antibiotics. Now that is the sorry state of affairs. I mean, as doctors, we don't make this distinction between all these conditions and just go on using antibiotics. And unfortunately, we also see lots of patients being given fluoroquinolones. Now that is doubly unfortunate. So first of all, I said that bacterial causes would be very unusual. Also, when TB is not ruled out in a high endemic country like such as ours, it is really very wrong to start this patient on fluoroquinolones, because remember, fluoroquinolone when given as monotherapy for TB can produce resistance within a very short time, like 10 to 15 days. And a very valuable drug for the use of TB is lost in the same patient. Okay, so that is why when TB is not ruled out in an endemic country, I think one should never be using fluoroquinolones. And I told you that for lymphadenopathy, there is really very little scope for using empirical antibiotics. What about diarrhea? Another very important cause of perhaps misuse. So you hear this is a patient who's otherwise healthy and everything. Watery diarrhea, vomiting for 2 days. He's stable. There's no blood, no fever, no tenesmus or anything. So again, what are the commonest causes? It's norovirus is one of the most common ones. You may have these other E. coli with particular properties. Rarely you can also have Shigella, Salmonella, and others. Rotavirus is much more common in children, but it can also be seen in adults. So again, what I'm trying to say is, by and large, viruses dominate this syndrome of an acute watery diarrhea or acute gastroenteritis. So again, the scope for using various antibiotics, anti-amoebic drugs and all is very, very limited. So rehydration is the cornerstone. There are some indications for doing a stool culture or this multiplex PCR, which I was telling you, so we can do that on the stool sample. And again, very few indications for using antibiotics. So if the patient is really very toxic, immunocompromised, has fever, has bloody stools, probably that is a patient where we may use the antibiotics. Interestingly, there is so much of fluoroquinolone resistance among the drug bugs in the bowel that really, these Ciplox or Ciplox TZ or some such combinations that we use have really very little role apart from being a placebo for us and for our patient. It's possible that azithromycin may be useful in this situation. Now let's look at skin abscesses. Now these are common again in our family physicians' practice. Most often they are due to Staph aureus, and that Staph aureus can be either methicillin susceptible or it can be methicillin resistant. Now here comes something which might be a surprise to many of us. So if it is a small abscess, it has already ruptured or has been drained, there's really no need for antibiotics. And if at all we have to use antibiotics, then they could be something which is designed for MSSA or MRSA. So for MRSA, it could be linezolid, but remember this drug is highly toxic and we need to use it very carefully. On the other hand, if you have cellulitis, which is a lot of redness, pain, swelling, but not much of pus formation. So such a cellulitis is most often due to not Staph aureus, but due to Streptococcus pyogenes. And interestingly, this drug is fairly susceptible. It is susceptible to ampicillin and amoxicillin also. It is not even beta-lactamase producer. So you don't even need clavulanic acid along with the ampicillin or amoxicillin. So just plain ampicillin, amoxicillin may be okay. Of course, you need to carefully see this patient to rule out more serious conditions such as necrotizing fasciitis. Okay, so when I talk of skin soft tissue infections, we have to guard whether this is possibly necrotizing fasciitis. And there are some clinical pointers which tell us that this is necrotizing fasciitis, where the pain is out of proportion to what you see on the surface. There could be patches of less sensation over that particular area. The patient is extremely toxic, high counts and everything else. And then there are certain imaging features and so on. So that is something which is to be guarded against, and that needs surgery. UTI is another common problem, and it's becoming so difficult in family practice, like what to do and which drugs to use. Like this is a patient who presents with dysuria, increased frequency, and but there isn't fever or vomiting. Urine shows a lot of pus cells, so this is a syndrome of cystitis. Now, how do you choose drugs empirically? And that is something which is not very easy to answer. Because of increasing resistance, it may be preferable to have a urine culture and use a treatment which is called as a directed therapy. So based on the culture. But is it really possible in clinical practice or in family practice? I don't think so. Because for this, you will need to have the culture and to the sense, and you might use some treatment, but you may want to refine that treatment based on the culture report. So if none of these things are possible, there are some of these drugs which we might use depending on the prior knowledge of local susceptibility. So I would suggest that fluoroquinolones is not really going to be very useful looking at our epidemiology. So maybe nitrofurantoin or Bactrim or cefixime, clavulanate, or even fosfomycin may be useful in such instances. So probably in a patient who's got just cystitis, which is the first episode and so on, maybe you don't need a urine culture, although scientifically speaking, it is needed. But patients who get recurrent UTIs, in such patients, you will definitely need it. That brings me to another very important clinical problem in practice, and that's pyrexia. It's certainly the cardinal manifestation of disease, probably the most common reason for seeing a doctor. But just give it a thought here. While infection is the leading cause, it is not the only cause. So when you suspect infection as the cause of the fever, it is if it is an acute high-grade fever, if there are upper respiratory signs and symptoms, certainly if there are meningeal signs. So this is definitely not going to be a non-infectious cause. It is bound to be infectious. Slides are not advancing. One moment. Yeah, friends, the cause of fever is to be determined from where that fire is. Okay, so if you look at this, you know that a fire is here, you know which organ is involved, and then you can direct your investigations as well as your differential diagnosis for that particular organ system. Why is it hanging? Sorry, it's going on the net again and again. I'm trying to advance further. Yes. Let me share it again. Okay. So there are some of these talking about many Falciparia and talking about streptococci, including pneumococcus, which can produce meningitis or
Yeah,
pneumonia.
now we are able to hear you.
Yeah. So these are some which are really fulminant symptoms. So in these situations, if you are suspecting one of these three, quick investigations and empiric treatment. But other situations, you have time. So there is some time for you to think where is the infection, which organs involved, and accordingly make a differential diagnosis and start. So for all this, you need a thorough and repeated focusing features and organ that involves cognition and important. Now this can be difficult when the clinical features are few or and any medical student or any one of us can easily diagnose, but the experienced clinician will have to have overlapping. So, difficult when you just of headache.
Voice is not clear still.
Not clear. Okay, just made us here, which with some of the important symptoms which we have in rash, what happens to the WBCs, what happens to the platelets, and these are some of the common infections which we see in practice. So depending on how can make about what might be the problem particular. How do we approach undifferentiated fever? So on day 1 and day 2, probably we don't need to do too much. We can just give symptomatic treatment, antibiotic. And 4, we probably do some simple tests such as CBC and others. And by day 5, if the fever panel and LT in order to come to some conclusion. Patient is telling the doctor, are you sure it is typhoid? My cousin who was being treated for typhoid died of malaria. So the doctor replies, don't worry, my friend, when I treat a patient for typhoid, he died of typhoid. Now this is really telling you what are the challenges of making the diagnosis and the challenges because the bugs have become resistant. So typhoid is not an easy diagnosis. There are no specific symptoms or signs. Then it lacks a simple diagnostic test. And let me tell you once more that Vidal is really of no value. Now, culture has to be done as well as looking at eosinophil count, which is really 0, can be quite helpful. But culture can be unreliable in some of the labs. There are difficulties of doing a bone marrow culture, which is actually something which may be needed after a long fever. And there has been this dictum, which is again told during days, that fever without an cause must be considered as typhoid. That has produced a lot of antibiotic misuse. And I really don't agree with this particular dictum. So clinical diagnosis of typhoid is certainly difficult. It simulates many infectious diseases which occur in tropics. Also simulates vasculitis, lymphoproliferative disorders because you may have lymphadenopathy and splenomegaly. The classic picture in text medicine is definitely now modern. It's not commonly sufficiently common or specific, but absolute eosinopenia, as I said, can help. Malaria, again, can have very, very non-specific features. But what is important is the classic paroxysm of fever, chills, and rigors at regular intervals, but a febrile period in the interim period. That is something which is important. So most of the time, the patients will tell you, I had 104 fever, I had 105 fever. But he's not telling you whether the fever became normal in between the two paroxysms. Okay, so this is something which we should try to elicit from history. Another interesting thing is in malaria, there is no leukocytosis, no lymphadenopathy. Severe malaria patients admitted to ICU may get secondary bacterial infection. That's a different thing, but that's a ICU medicine. ICU features, that is something in family medicine. Leptospirosis, we all know the features, but we also must and with certain epidemiological exposure, such as wading in rainwater or flood water or something like that, and what are the features of that. These are a few examples where specific bacteria and specific treatment is involved. But before that, I told you a lot of examples where most of the time that syndrome is because of viral infections. So the specialist knows more and more of one thing, but in the end, he knows everything about, and therefore, again, if you are not a specialist, you are a physician, you are the first person who's going to encounter, I think your job is extremely difficult. And we will try to sort out many of the problems, but it is not really very easy. And therefore, a continuing study, observation, as well as building on your own clinical experience, with the help, of course, of some relevant tests, is something which is very important. So what are the problems in India and in developing countries? Obviously, we know that there is lack of sanitation, there is overcrowding, the lack of infection control practices. There is also, understanding about collateral damage. That is the effect of antimicrobials, which is going to be that is something which is very, very important. Now, the lack of microbiological facilities is ability to interpret these results. And even if your facilities, you have little or no confidence in them. These are some of the problems which we have. On the other hand, you have widespread availability of antibiotics and so many combinations. You also have a large number of patients with growing expectations to be treated within short periods of time. And for all reasons, antibiotics are used as antibiotics or as substitutes for diagnosis. Now, this is the unfortunate reality in our country and many other developing countries. So it takes a long time for you to think, convince the patient why I am not giving an antibiotic. On the other hand, it takes only 30 seconds to write prescription for antibiotics. So there is a tendency of physicians to leap on each new antibiotic or a new antibiotic on a new toy. A toy like this is something which is a double-edged sword. You use it and something out of it. People need antibiotics, but maybe having new antibiotics have to use effectively. You can't use antibiotics instead of infection control measures, instead of good hygienic measures. So if you don't have good sanitation, good water supply, good air quality, how can we use antibiotics because we don't have any of these things? So that is something which is we really need to look at, and our government needs to look at. That brings me to my colleagues, and there I would say that withholding antibiotics is actually the most difficult job, and that was trying to sell matches on a night in Scandinavia on a winter's night. Okay, so the passers-by were going, but nobody was buying up matches. It was extremely cold, so the girl had no other alternative but to strike a match to keep herself warm. Soon she runs out of matches, and she's found frozen to death passers-by. I have a box of antibiotics. Every time we use an antibiotic, we get fine. Just remember that we are using up a non-renewable resource. So that every it's a non-renewable using, and just close an empty box, which was what happened to this little girl. So about it, whenever going to And one quote from this great man, a problem cannot be solved by the level of thinking that created it. Okay, with this thought, I view and stop my screen share. If you are going with that, I am turning it over to Dr. Asrani.
Thank you. There are some questions.
Yes, yes, sir.
For antibiotic, sir, then when to decide for antibiotics?
Sorry, what was the question?
Is green and yellow sputum not an indication for giving antibiotics? Then
Yes.
what is the criteria for deciding antibiotic?
Yes. So if we are talking about sinusitis, or what are we talking about? If we have the patient is having a lot of sinus tenderness, headache, and so on, and if the patient is not responding for 5 to 7 days, then there is an indication for using antibiotics.
How important or necessary is it to treat E. coli cysts found in stool for a patient who is a food handler?
What is found in the stool?
E. coli cysts.
Acha, okay. So those are the these Antimiba histolytica cysts, you mean, no?
No, not E. histolytica, E. coli.
The E. coli doesn't produce cyst.
That is what the question is. I think there's a mistake.
Yeah.
Should we treat amoeba cysts in food handlers?
Yes, definitely we should treat in food handlers by using specific drugs for the cysts, which is not actually metronidazole but diloxanide furoate.
Okay. Now there is a query. We all know about the genome project being undertaken by Harvard Medical, which aims to radically change the treatment approach by targeting genes causing morbidity, which may replace antibiotics for many illnesses. Though a distant dream, your thoughts on the same?
Right. So, see, trying to find out which is the organism and what through the genes which are detected is going to be a very lofty goal. And although it appears to be something which is going to be very useful, we still have to sort out certain problems like whether this organism or the genes which have been found of this organism, whether that is the cause of the patient's problem. So that kind of clinical correlation with these with the genetic material which has been found is going to be very important. Let me tell you one thing: whenever new tests come, we think that the problem is solved, but unfortunately, we are exchanging the new problem with the old problem. So later on we will have to understand how to interpret the genetic reports or whatever reports come up which detect nucleic acid material and so on. So like I told you, this PCR microarray is an exceedingly good test, but as a clinician one will have to correlate it with the clinical picture to see what is there. And even in this test they have a limit up to you can find out about 10 or 14 organisms, but there could be organisms which are beyond that also. So clinical correlation is really something which is very important. Thank you.
Okay. In calculating dose of antibiotics, there is generally a range given: 8 to 10 milligram per kg, 35 to 50 milligram per kg. How to decide lower side or upper side?
Yes. If you are dealing with a serious infection, if you are dealing with an infection which is in an area where the penetration of antibiotics is not very good, then you should always use the higher particular dose. My personal philosophy is giving a higher dose is always better. A lower dose is not so good when we are treating infections, because that leads to selection of more resistant strains. See, you have a large bacterial population of which some strains are more resistant. You give a lower dose and only the susceptible organism population is wiped out. So you are left with the more resistant population. So my personal preference is to use the highest tolerated dose rather than the smallest effective dose. Okay, this is a very general statement. We have to use it on a case by case basis. But my personal suggestion is to use the high dose whenever possible, but for a short duration. The duration should be as short as possible, but the dose should be as high as possible.
Is there any way we can know if the patient is allergic to a particular antibiotic when there is a history of allergy to another antibiotic?
Yeah. This doesn't have a very short answer, but we have to think of the previous history and whether that history is also convincing or not. Sometimes some patients may tell you that there is some allergy, but it's not highly convincing. If you see about cephalosporins, then first, second, third generation cephalosporins behave in a different way. Okay, so the least allergies to the third generation cephalosporins and most to the first generation cephalosporins. Only about 30% of patients will have a cross allergenicity between penicillins and cephalosporins. Then about sulfonamides, again, sulfonamides will definitely, if there is a prior history, then we should definitely avoid sulfonamides. So that's definitely an important thing. About aminoglycosides, comparatively, they are not allergenic to that extent. Tetracyclines and all can produce more of skin reactions, fixed drug eruptions, and so on. So it's on a case by case basis. There's no one quick answer to this question. It's a very important question, nevertheless.
If somebody was antibiotic allergy 7 years back, will the allergy continue lifelong?
Very likely, yes. But again, I'm telling you that it's very important to know what sort of allergy. Was it just a skin allergy or the patient had anaphylaxis, anaphylactoid problem? So if it was a severe allergy, then we should not take a chance to use that particular drug at all. If it was a mild one, we could use it carefully under some good supervision.
Penicillin used to cause anaphylaxis. Now we have seen anaphylaxis with NSAIDs. Do oral antibiotics like cephalosporin, amoxicillin can cause also anaphylaxis?
Yes, they can also cause anaphylaxis. It's not based only on the route of administration, but overall penicillin and ampicillin, or means penicillin after all, has a higher tendency to produce anaphylaxis as compared to cephalosporins.
Thank you. I would request you to please cut the cake and give it to your family members, including your mother.
Okay, I will do that certainly with pleasure. How it won't be visible to you, no?
Just show us once and then you can cut it.
Okay, okay. Can you see it? It's a beautiful cake, and there are two happy occasions today. It is the 101st lecture, as Chandu has said, and also it's my mother's 19th birthday. So it's really a double occasion of pleasure for me. And I hope this is the not the last time that Chandu you are going to call me for your
No, we will call you very often. I will have a word with you separately.
Okay.
The course that you are conducting in Jupiter.
Right.
I would like a similar antibiotic course for doctors online, for general practitioners.
Okay.
I'll talk to you on a separate line. Even
sure.
Dr. Alka ma'am also wanted to set up something on infections.
Right.
So let's make it our goal and keep doing it.
Yeah. And Suhas is also there.
Thank you very much. Thank you.
Thank you. Bye.
Bye. Bye. Take care.
Sorry that connection was a problem, but I'm glad that all of you stayed till the end.
I know technology is never in our hands.
Yeah, you know that I changed over from that dongle to my phone, then back to the dongle and tried some jugglery, but it was
no issue, sir. No issue. No issue. Yeah. Okay. Bye.
Okay. Bye.